Good morning, everyone. This is ARS 2023, and I'm Shahid Reyes. I'm really privileged today to be with Dr. Saroj Neupane at ARS 2023. Saroj, always nice to be with you.
Yeah, happy to be here.
Yeah.
Thanks, Shadi.
Yesterday, you gave a phenomenal talk about high risk or PCI in high bleeding risk population. It's a very important topic, and our population growing, so the risk is higher. So, what is up to date on that topic?
So, if you look at the patient population we treat in our day-to-day practice in cath lab, we are treating older patients with more complex medical problems. And if you just look at the definition of high bleeding risk, it basically includes probably over 75 to 80% of the patient we treat in the lab.
Yeah.
As the older age, anybody with an oral anticoagulation, if they are anemic or liver disease and so forth. So we do have to modify the PCI based on their bleeding risk. However, since majority of the patients that we are treating are at higher bleeding risk, it's sort of like just following the standard PCI practices. That means managing your anticoagulation well. For example, in STEMI, using bivalirudin to reduce the bleeding risk complication, potentially also improving survival. There are some new data that came out last year, as well as changing the axis, trying to do these cases with radial so that you avoid growing complication and things like that. And ultimately, when we do a PCI, we just got to do a good job of doing a PCI, how we can use all the tools and techniques in the lab, such as physiology and intravascular imaging, so that we get optimal stent results in these patients. And ultimate goal in these patients, like you want to take off of DAPT as soon as you can. And once you utilize the intravascular imaging and physiology to perform PCI in this patient, I think that will give you extra confidence to stop DAPT after a certain period of time.
You touched on a very important topic, the DAPT. So, from your practice, when we should stop and what agents do we use in this population for DAPT?
So it's a little bit controversial, or like sort of like I don't think there is any standard practice. But if you look at the guideline, what it says in stable CAD patient, you continue DAPT with aspirin and clopidogrel for 1 to 3 months, and then you de-escalate either clopidogrel monotherapy or aspirin monotherapy. Whereas a patient with acute coronary syndrome, you treat them with aspirin and one of the potent antiplatelet agents such as ticagrelor or prasugrel, continue for about 6 months, and then de-escalate based on their bleeding risk and ischemic risk. In my practice, I do it a little differently. If they are in stable CAD, I put them on aspirin and clopidogrel and stop clopidogrel after 1 to 3 months. Also, we do have to look at the complexity of the lesion we treat. So sometimes we may have to extend up to 6 months. If they come in with acute coronary syndrome, I start them on aspirin with ticagrelor or prasugrel, and after 1 month, I de-escalate to clopidogrel and continue for 6 months.
But this is what you're doing also, I think, is part of the European guidelines. It's kind of a little bit ahead of the US in terms of duration. It's shorter than the US for ACS as well stable.
Exactly. They always have been a little ahead of the game, or a little more progressive than us in terms of guidelines. And also there was a recent meta-analysis, rather than using this blanket aspirin clopidogrel or aspirin ticagrelor or prasugrel, that we should escalate or de-escalate based on their bleeding risk and ischemic risk. And that also, it's not just one point in the time. I think it's more like continuous. You got to reassess it in 1 month, 3 months, where they are in terms of their bleeding and ischemic risk, and then decide on your escalation and de-escalation strategy.
So take-home messages: use physiology and imaging. The type and location of the lesion is important. Dictate the duration of do antiplatelet.
Absolutely.
And then stop as soon as possible. The outcome is good if you utilize imaging properly.
And then lastly, there is some reservation about using drug-eluting stents in this patient, where people are still using bare metal stents, but they have enough data now. Drug-eluting stent with 1 month of DAPT is safer than bare metal stent.
Very important point. Saroj, thank you so much for your time and for your insight on this important topic. Watch these videos and others on our YouTube channel. This is Shahid Reyes from St. Louis.
Thanks, Daddy. Thanks for having me.